Welcome, everybody. I'm Brian McCourt, and on behalf of the McCourt Foundation, we'd like to welcome you all here for the 2024 Neurological Symposium. This is our 21st symposium, so we're going back many, many years before Zoom was around and all of our technology. So we were all here in a big room with no face masks, so times have changed. I'd like to thank all of our sponsors, but in particular, Eisai Pharmaceuticals and UBS as our major sponsors, but as well Biogen, Genentech, TG Therapeutics, MT Pharma, and again, a lot of them will have their display tables, very knowledgeable on many of the topics that are being talked about here and therapies related to it. So please take the time to visit them. You know, our mission, I'm sure a lot of you know, is striving to cure neurologic diseases while empowering others to build a healthier world. And we're governed by three pillars. The first being research, next is education, and then partnerships, which we use our events to partner with other health-related, you know, in areas that help promote healthy living, healthy lifestyle, and we do it again in Los Angeles and here in Boston. So, you know, education obviously is extremely important, and access to these physicians and the minds, some of the best minds in the world, is really, really in need, the direct access. And today we have, with the Zoom sign up, and again, you know, times have changed in that convenience is extremely important to patients and caregivers. So we have 11 countries and 25 states that are taking part, that will be right now, again, Zooming in, and we're happy to have them. But thank you to the doctors and the hospitals, as well as all of our nonprofit partners. The doctors, you know, dedicated to making sure that they provide the latest. They basically do this for free. So it's been a great partnership with them. You know, thanks to our staff here, you know, specifically Rosemary, Kelsey, and Matt, but as well our whole staff out in LA. Thanks for making this happen. And with that, I'd like to introduce our moderator and our first speaker, and Michael Erkden. Erkden. Come on up, Mike.
All right, well, it's a pleasure to be here. This will be the Alzheimer's section of the morning, of the day. And we've got two speakers, myself and Dr. Ramirez here, who's going to be speaking on caregiver supports and mobile app interventions. So a very exciting sort of morning ahead. Thank you. So why don't we get started with my talk here? So really, it's really going to be an overview of new disease-modifying agents for Alzheimer's disease. We're in kind of a new era of Alzheimer's disease, and I'm excited to be talking about some of the updates that we have. So, as background, I know a lot of the folks in this room and online hopefully know this already, but Alzheimer's disease is common. About a quarter of those over the age of 65 have MCI or dementia. And about half of MCI is caused by Alzheimer's disease. So there's enormous, numbers of people in the U.S. and across the world who have Alzheimer's disease in the brain. And historically, our approach to treatment for Alzheimer's has been really a mix of kind of chronic disease management and really kind of long-term but palliative approaches. So, one approach is to target symptoms with, medicines or non-pharmaceutical interventions. We look at modifiable factors that might make things worse, right? So if someone is on an opiate, but they also have Alzheimer's. We want to make sure that they're, not on too much of an opiate, so it makes the memory worse, and things like that. Or if they have a low, vitamin B12 level, let's make sure that's fixed. So that is kind of a modifiable factor that we can help to optimize their brain health, and that can actually make a big impact. There's some studies now that say about half of all dementia is sort of attributable or in some way, exacerbated by these, modifiable, risk factors. We really focus hard on healthy lifestyle practices: exercise, eating well, sleeping well, not using excessive amounts of alcohol, being social, and using one's brain every day. And those healthy lifestyle practices are known to make a difference. And then, of course, we think about safety, right? Operating, a car or other heavy, tools in things like that, and to make sure that folks, well in advance of when it might become an issue, have things like healthcare proxies and a durable power of attorneys set. AD, as we all know, has a high cost to patients and caregivers and society at large, and of course the cost is financial, but it's much more than that. There's hours of unpaid work, there's psychological costs, and perhaps spiritual costs, as those who have a loved one with Alzheimer's can attest. So when we think about Alzheimer's disease, we think about the disease itself in the brain that injures one's brain and causes changes in the way the brain works, right? And then when the brain's not working well, it causes symptoms. And historically, our approaches have been targeting the changes in the brain the way it's working. That's sort of, a middle stage. We haven't yet been able to go to that, earliest stage, right? So we basically are targeting the effects of Alzheimer's disease on one's symptoms. So, for example, things like Aricept or donepezil, it actually, in people with Alzheimer's disease, they have a low level of acetylcholine, and it brings that level up into a normal range and can help with someone's symptoms. Or with, memantine, that's a medicine, how that works is when the brain is injured, it releases excessive amounts of a neurotransmitter called glutamate, and all that extra glutamate is toxic, and memantine helps to ameliorate or at least lessen how much toxicity there is, and so on and so forth. You can see how we're actually targeting the effects of Alzheimer's, but not the actual disease itself. In the past year or two, we now have new agents listed in green here that are directly targeting Alzheimer's disease itself in hopes of actually not allowing those downstream, neural changes to happen in the first place. And this is the new drug, lecanemab and others, like it. They take out a protein called amyloid, which is abnormal in Alzheimer's. And this offers hope that there may be long-term disease modification as opposed to the disease having its effects, and we're kind of trying to react to the symptoms after the fact. So what is lecanemab? Well, it is a anti-amyloid antibody. So just to give a little bit of background, in Alzheimer's disease, you have amyloid as an abnormal protein, and you have a tau. And these proteins collect over time, and they spread over years. And as they spread, they cause those tissues not to work as well, and ultimately to wither. And that leads to the symptoms of Alzheimer's disease. So with lecanemab, this is an antibody. It binds amyloid, and it takes the amyloid out. And it uses the immune system to do that. It is administered IV every 2 weeks for at least 18 months. There's an ongoing debate about whether or not staying on treatment after 18 months has a benefit or not. But at least you're on it for 18 months. It's FDA approved, which means it's FDA approved for the early stages of Alzheimer's, MCI or mild dementia, that's caused by Alzheimer's disease. So what is MCI? Well, it's an acronym, a mild cognitive impairment, and that's when you see evidence of memory loss on testing, but yet you're able to do your everyday activities on your own. That's what MCI is. Whereas mild dementia is when you have evidence of memory loss on your testing, but yet you're needing some help with your everyday activities, but you're not needing help with the very basic activities, right? So if you need help with bathing yourself or feeding yourself, that would mean you're no longer in a mild dementia stage, but you're in a moderate dementia stage, and you'd be ineligible for lecanemab. And what is meant by due to Alzheimer's disease? Well, historically, doctors have just looked at symptoms and one's scores on a cognitive test in an MRI scan and so on and so forth, and made an inference based on all of that they think Alzheimer's is in the brain. But now we have much more advanced testing that can look specifically at markers of Alzheimer's disease specifically. You can actually see the amyloid and sometimes even the tau in the brain. So we have now folks who are thinking about being on lecanemab have to have a positive amyloid a test that we actually can see, and inference isn't enough. So how do we know lecanemab works? Well, there was a large phase 3 trial called Clarity AD. 1,800 patients in total. About half of them were on the drug. Half of them were on a placebo. All of them had MCI or mild dementia. All had a score on a test called the MMSE. It stands for Mini Mental Status Exam. It's a standard exam that has been used for a long time that allows us to kind of stage one's memory. And they had to have some evidence of a memory loss on some cognitive testing as well. And I will say an MMSE score of 21 or 22, actually it's about 21, aligns with what you might expect for someone with MCI or mild dementia. It means you couldn't have a big mismatch in between one's a testing and then one's clinical diagnosis of MCI or mild dementia. There's a test. There's a measurement called the CDR. That's another acronym. You'll see a lot of these today. That stands for clinical dementia rating score, and that's a kind of a comprehensive assessment of one's everyday functioning. It's probably the best tool we have to stage one's dementia. So a CDR of 0.5 is roughly about MCI level impairment, and a CDR of 1.0 is roughly mild dementia. So everyone had to be on these having these scores. Everyone had to have evidence of amyloid in the brain, either via an imaging test that's called an amyloid PET scan, or to have a spinal tap looking at cerebrospinal fluid, CSF, and that if they showed a low evidence of Alzheimer's disease on the spinal fluid, then that would make them eligible to be in the study. And anyone who had a brain hemorrhage on MRI scan or multiple little areas of bleeding were excluded from the trial on their MRI scan at baseline. Interestingly, folks were allowed to be on anticoagulants, so things like Eliquis, Coumadin, and things like that. And again, it was 18 months long. And what it shows is that lecanemab takes out amyloid very, very well. You can see on the upper right when the blue line are folks on the placebo, and then people on lecanemab, and the y-axis here is how much amyloid has been taken out. You can see really you have a very large and successful removal of amyloid when you're on the drug. In fact, about 80% of those had no amyloid left as far as you could see on an amyloid scan after 18 months. So they essentially took all the amyloid out. And that was also shown on the spinal fluid as well. The main outcome here that we're interested in is that lecanemab has a clinical benefit. So what it shows is that when you're on the drug, your rate of memory loss slows over time. But importantly, your memory, it doesn't improve, and it doesn't even stay flat. your memory is still expected to get worse over time, but just at a lower rate than if you were not on the drug, okay? And that also was shown to have it also allowed folks to be independent, longer. It led to about a 5 months time savings over the 18 months of trial. It was interestingly, the thought is, well, perhaps you take out amyloid, and you have this effect. Does it also affect other markers of Alzheimer's disease, right? As we mentioned earlier, Alzheimer's is not only amyloid. There's this other protein tau, and it has other effects on the brain. And there was evidence that by taking out amyloid, you actually had an effect on other, markers of disease, tau levels and others, and that's shown here. Again, I'll skip over some of the, small details. So that's why you would want to be on it, right? It takes out amyloid and it slows your memory loss. Great, this all looks awesome. Why wouldn't you want to be on it? Well, the main reason is a side effect called ARIA. It's an acronym, ARIA. It stands for amyloid-related imaging abnormalities. And what ARIA is on an MRI scan, you see areas of swelling and or a bleeding, okay? And it's not, and so it sounds, scary, and at times it can be. 1 in 5 on the drug will have ARIA, right? They'll see these areas of swelling and or hemorrhage on the MRI scan. And it's most apt to occur in the first 6 months of being on the drug. Some reassuring things is that most ARIA is asymptomatic. Only about 3% of everyone on the drug will have symptoms of ARIA. And if you have symptoms of ARIA, they're usually mild. A mild headache, some dizziness, fatigue, things like that. ARIA almost always resolves on its own within a couple months. But importantly, there are rare but serious cases of ARIA, where people have had a lot of swelling in the brain, a large bleed. In fact, some people have died of ARIA. So while that's a very rare, well less than 1%, it can happen. It's important that folks who are thinking about being on this drug are aware of that. So because we take ARIA so seriously, what are the actual risk factors for having ARIA? Well, one is on that MRI that you had to have before you were on treatment. If you see any areas of hemorrhage or bleeding on that MRI scan at baseline, you'd be out because it would be unsafe. Your risk of having subsequent hemorrhages on the drug would be too high. At least that's what we would expect. There's a gene called the ApoE gene, and many I suspect have heard of it. It increases your risk of so it comes in different forms. E2, E3, and E4, and the main form or allele that we worry about is called E4. And if you have one copy of E4, it can actually, let me say this in a different way. E4 not only raises your risk of having Alzheimer's disease in the first place, that's what it's well known for. It also raises your risk of having ARIA. And if you have one copy of the E4, your risk is a little higher. If you have 2 copies, it's a lot higher. So we have specialized protocols at our center for folks who have 2 copies of the E4 allele of the ApoE gene. And we take ARIA very, very seriously, as do all centers who are offering this. There is a requirement on the FDA label that you have to have an MRI scan looking for ARIA right before your 5th, your 7th, and your 14th infusions. So we look very hard for ARIA and try to get ahead of it. Then, of course, if you have ARIA, you can either, if it's mild and it's asymptomatic, you can sometimes actually just stay on the drug with more irregular MRI scans. If it's bad, you may have to stop it. And perhaps if it's really bad, you aren't allowed to go back on it. So there's a range of responses if you have ARIA. Okay, and then of course, if you're ever in the emergency room and you're on lecanemab, there was a case report, meaning there was an example of someone who was on they had a stroke for unrelated reasons, which happens in older adults on occasion, and they got a drug called a TPA. It's a drug that kind of breaks up a clot and it's a commonly used drug when someone has an acute stroke, and they had a large fatal hemorrhage. So we would say anyone on lecanemab should not receive those kinds of medicines that can break up a clot if they have an acute stroke. But there's other ways to manage a stroke. You can take out a clot with a manual stent retriever, and you can even use things like aspirin and other drugs that aren't quite as potent. So that's kind of our response to this, elevated risk of using these, clot breaking medicines. So what are we doing at Mass General Brigham? This drug is here, and we've actually been using it for the better part of a year, and I thought I would just kind of share about our institution's experience with this. So hopefully others can learn from it. So what it is, it's really our clinical program that's designed to deliver these new advanced Alzheimer's disease treatments. And the number one, a reason why we exist is for safety, right? ARIA is a big deal. You don't want to miss it. So that's our number one reason for having this. But also we want to be able to provide, a widespread equitable access and to be efficient, right? If there's a lot of folks who want to be on this, we want to make sure they have access to it. So we really have a two-stage process. Our first stage is looking for folks who are eligible, who are appropriate, right? So we get a history, an examination, an MRI scan, an ApoE gene test, either a spinal tap or an amyloid scan, all the things that we talked about earlier. And we make sure that they fit a profile that is apt to have a benefit and is not likely to have a bad side effect. So we really, and then we obviously would make sure that any patient who's interested in enrolling in this is well informed as to the risks and the benefits, and they have the opportunity to align that with their own personal values. So it's very important that this be a individually, a tailored decision. And then once they've agreed to it and they want to be on the drug, we start the infusions. And then at this point, it's every 2 weeks IV at one of our infusion sites. And we get the MRIs as scheduled. And then we actually reach out in advance of every infusion. And if they have new symptoms, but it's not at one of those intervals where they're due to get an MRI scan, we sometimes might get an extra MRI scan, right, just to make sure that ARIA hasn't happened in the interim. This program is highly focused on lecanemab. As folks here know, caring for someone with Alzheimer's disease is a much larger process and requires a lot of hands-on work. And this particular program is focused on the lecanemab element. And some of the other work, talking to a social worker, ordering Aricept, memantine, things like that, that's done by their other doctor. And this is it's been a really nice collaboration between MGH and Brigham in Women's Hospital, especially as we've kind of started to integrate our services more. This is just a group of people who are on the team that have been working on this, and we actually meet every week a few times. So we meet on Wednesdays, and we talk about cases that perhaps are on the kind of edges of eligibility, right? We want a strong consensus about who's a good fit and who's not, and make sure we have a good reason why. And then we also talk about our approach as the science evolves, and as we're getting more info about how these drugs are working. We try to update our own, a way of offering treatments. So just to make sure that we are on the state of the art. We opened up our clinic just about a year ago, and we've started infusing a few months later. So in the past, 10 months or so, we've seen over 400 patients in our clinics. We've ordered a lecanemab over 350 times. We've started over 250 patients on the drug, and we've had a total of about 2,000 infusions. So we've had a lot of, a rapid expansion, again, trying to meet the needs of our communities. We are in the process of expanding access even further, and we expect our access to even grow multiple times over the next year or so, which is exciting. Here's what it looks like if you make a referral. We'll ask your doctor to weigh in on all of these issues. I won't, belabor this a lot, but I'll just say you have to have MCI or mild dementia. Alzheimer's has to be the main reason for your symptoms. If you have some other disease or illness, that's a main reason for your symptoms. You wouldn't want to take on the risks of this drug, right? If it's not going to help you. You have to have an MMSE score or these other tests that are related. And you have to have an MRI within a year. And of course, you have to have an amyloid scan or a spinal tap. Again, we will order the amyloid scan and the spinal tap either or. It doesn't have to be both. It can be one or the other in our own clinics. So you don't have to have a doctor who knows how to order that. We will take care of that for you. After someone is referred, we review everyone's chart and make sure there's no reason. Obviously, that would exclude them, right? If they were referred, but they were on an anticoagulant, and we think anticoagulants are unsafe, we wouldn't have them come in for a visit if we know they're going to be ineligible. And then we might, once you're scheduled, we kind of spend the first couple visits looking at all your data and actually, ordering those amyloid scans and ApoE gene tests that we might need to, finalize your data set in order to make a decision. And then after that, you would start your infusions at one of our MGB infusion sites, and you would come back and see us in the clinic every 6 months. We'd look at your MRI scans as they happen over the first 6 months as well. And again, order extra MRIs if we need to, if you have new symptoms that might be consistent with ARIA. So that's what we've done for lecanemab. As many know, there's a new drug now that's FDA approved called donanemab. And it was approved over the summertime. And it's very much similar to lecanemab with a few differences, which we'll talk about. But again, it's an anti-amyloid antibody. It gets infused every 4 weeks now, as opposed to every 2. It binds amyloid and it takes the amyloid out. And the main differences with donanemab are that it's dosed again every 4 weeks, whereas lecanemab is every 2. It has higher rates of ARIA relative to lecanemab, and there are more MRI scans in the first 6 months. So there's some upsides. Once a month, IV dosing is easier than once every 2 weeks, especially if you're coming in from a far distance. But the downside is that there's higher rates of ARIA. I can go through this fast. It's a very, very similar design in terms of a trial. The one difference is that, again, we mentioned the every 4 week, a dosing, and they actually had a mechanism for coming off the drug. So they got amyloid scans at 6 months and 12 months and 18 months. And if you didn't have any amyloid left on those scans, you were then switched to being on the placebo. So they had a mechanism for how to stop it, whereas lecanemab didn't have that in their trial. Similar data, it takes away the amyloid very, very well. Again, about 80% of folks on the drug were amyloid negative. They didn't have any amyloid left on the amyloid scan at 18 months. It shows a very similar, change in one's CDR score or one's, memory loss over time. Again, similar efficacy or effectiveness as was lecanemab. It had higher rates of ARIA, so there was about 40% had ARIA on their MRI scans, as opposed to 20% for lecanemab. A 6% rate of symptomatic ARIA, as opposed to a 3% a rate for lecanemab. And a 2% had serious symptoms of ARIA, whereas it was less than 1 for lecanemab. And in the trial itself, there were actually 3 ARIA-related deaths. So important to note that there's some differences in safety, but there's some advantages to being on donanemab. We're working to get this on our formularies now. It's not available here yet, meaning at MGP. But we hope to get this on the formulary and to offer it to the right folks by sometime later in the year or early next year. So what is this? So we've kind of reviewed this state of the art here for Alzheimer's and disease-modifying agents. What does this mean for the future? Well, one is I think we've got to make sure we identify the right folks who are on this, right? There's a few thoughts. One is there's a large number of people right now who have MCI who aren't aware of these drugs and don't know about them, and they may benefit from a formal diagnosis because they should have the opportunity to elect into being on these drugs if they're interested. And right now there's not a perhaps not a large awareness of how these drugs work and the fact that they work best early in the disease stage. Another future thing that might happen is right now it's IV infusions. You have to go physically to an infusion center and get infused. But I know there's interesting work on a subcutaneous formulation, which would then alleviate the need for being at an infusion center. I think we've focused here on anti-amyloid treatments, but there are non-amyloid related Alzheimer's treatments as well, right? There's tau. We mentioned that other protein earlier, but there's anti-tau treatments, right? There's what's called an antisense oligonucleotide that can reduce the intracellular expression of tau, and that's in trials now, and there's some excitement around that. Or perhaps if that works, maybe using that with an anti-amyloid antibody to get a better effect. Again, these are not here yet, but these are where things you perhaps are headed in the future. And then there's other mechanisms as well. One exciting area is looking at, so what's interesting about Alzheimer's is that there is amyloid in the brain many, many years, well before the onset of symptoms. So you can have amyloid in the brain, but yet you don't have symptoms, you'd never know. But you can measure the amyloid in the brain with a test. And there are some trials that are active, including ones at our site. It's called the AHEAD trial. And it's looking for folks who are cognitively normal, who have amyloid in the brain, and randomizing them to receive either a lecanemab or a placebo. And the hope is that you can actually prevent the onset of Alzheimer's in the first place. And that would obviously be a game changer. Again, that hasn't, we expect that won't be done for a few years, I don't think, so we won't have that answer soon. So that's all I had to say. Thank you. We've listed our Alzheimer's Therapeutic Program website here. We also have, I meant to put there's a brand new a website for the Center for Alzheimer's Research and Treatment, and we have a representative here in the back if you're interested in learning about that. And also we have representatives here at the Mass ADRC who would love to show you more about what we have to offer here too. So thanks. I will end there. Thanks. Yep.
And as I mentioned, I'm going to talk here about caregiver support interventions. And we know that the person living with dementia and her caregiver share a journey. I first realized this when I was in med school in Colombia, where I am from, if you have noticed my accent. And I was a student working in the neuroscience research group, taking care of people with early onset Alzheimer's disease due to a genetic mutation, and they would have dementia in their 40s. then I saw firsthand the journey that not only the person living with dementia, but also their caregiver had to navigate. We know that family caregivers of patients that live with Alzheimer's disease and related dementia provide a very needed and valuable service. And to this moment, despite having new treatments for Alzheimer's disease, which are not a cure yet, we know that the caregivers are the most effective intervention for the person living with dementia. So caring for the caregivers is something very important that we must acknowledge and take action and do. We know that one of the consistent risk factors for institutionalization for a person living with Alzheimer's is the psychological stress and depression of their caregiver. And every year, a patient that is at home saves the healthcare system more than $50,000. And not only to say the amount in dollars, but also at home, many of them would receive more humane care, being surrounded by their loved ones, by their people that really care about them. And also, if we continue at this pace, at the current pace, the federal costs just for people living with dementia would exceed more than $1 trillion by 2050. We know that the caregivers also face a number of challenges when caring for their loved one with dementia. They may not only feel overwhelmed while caring for themselves and the other person and all the things they have to do on the day-to-day, but also we know there is a loss of reciprocity in that relationship because it may be the spouse, or it may be that a person is taking care of their parents, or their mom or dad, and that relation is not going to be the same because the caregivers take on a new role of protecting, caring, providing care, supervision, and all their needs. There are also difficulties understanding and mentalizing others, and I am going to come back to that word mentalizing. But here is to say that when a person living with dementia may have certain reactions, behaviors, or things that they do, and the caregiver doesn't understand why are they acting that way, it's important to put ourselves in their shoes to understand where they are coming from. The caregivers also need to cope with an increased physical load, and they also have and experience reduced connections with the community because, as you can imagine, they are providing this care for the person living with dementia and helping them with their tasks, therefore have less time for themselves. There are also psychobiological consequences for the caregivers facing this stress and these challenges because they may experience higher rates of depression, anxiety, difficulties with their sleep. They may even have difficulties with their own memory and difficulties executing tasks and keeping track of all the many things they need to do now. They also have higher risk of cardiovascular conditions such as stroke and hypertension. And not only that, but they also have alterations in their immune system. For example, there are studies that have shown that caregivers under a lot of stress when they receive a vaccine, their immune response to that vaccine is a lot lower compared to people that are not under the same amount of stress. The good news is that there are key strategies to manage these complicated, stressful relationships, situations like those of caregiving. And some of those include mindfulness, mentalizing, and creative imagery. To start with the mindfulness and how it reduces stress, probably many of you have heard of this already because it's in the news, there are so many resources and things that promote this type of wellness intervention. And mindfulness is focusing on the present moment, on the sensation, on the experience, on your feelings without judging them, observing them with curiosity, describing them. But one difficulty is that mindfulness focuses a lot on the person, focuses a lot on the self. And in caregiving, we have this other person that we are providing care for. So that's one of the limitations there. Mentalization refers to understanding our own feelings, thoughts, desires, needs, goals, emotions, and also understanding their others, feelings, emotions, needs, desires. So these, as the graphic shows, it really incorporates not only our feelings, but the feelings of the other person. In this case, the person living with dementia. And that's how mentalizing can help in addition to mindfulness. And we have created, I work and I have created this with a colleague in psychiatry, Dr. Felipe Jain, this technique called mentalizing imagery therapy that I'm going to abbreviate as MIT, which combines mindfulness and mentalization through powerful, creative, guided imagery exercises. And as it is depicted here in the pictures, first we start with exercises that focuses on the body, on our awareness, on our relaxation. And with mindfulness, we focus on the present moment. And with the imagination, we are able to create this imagery in which we see the other person, where they are coming from, their emotions, their feelings, their reactions, why they are behaving in a certain way. And that helps us understand that and also reacting to those behaviors in a different way with more compassion and acceptance. We have done extensive research with MIT, and we have shown in several studies that it reduces depression, anxiety, and stress when compared to people that go through current standards of care, which is being part of a support group. And what we show here in the graphs is that people that have done the MIT on the left of each graph have reductions in the symptoms of depression, both right after the groups and at 4 months. Similarly, decreased symptoms of anxiety and reductions in stress. In addition to that, the people that have participated in our MIT intervention have increased positive traits in qualities such as being more mindful, having more self-compassion, and happiness to go through this journey that they are confronted with. And something that we don't talk much about is suicidal thoughts. Because even if we don't want to say it or we don't want to mention, it's a reality. And caregivers, when they feel overwhelmed and faced with a lot of stress, they may think about dying too. And we have found in our studies that when we ask about these thoughts, 30% of the caregivers express these thoughts of dying. And what we have found with our intervention with the MIT in the green box is that people that have gone through the MIT intervention have reduction in those thoughts compared to the right part of the graph in which you see the green box is smaller. So there are no reductions. If you have those thoughts of dying and you participate in the MIT, chances are that those thoughts will decrease, and it wouldn't be the same if you are just part of a support group. We have also found mechanisms of how this works, and we have found through doing studies with functional MRI, which are pictures of the brain and how it works, that there are a strengthening in certain areas of the brain, such as the dorsolateral prefrontal cortex and other emotional control networks that are associated with the improvement in both depression and decrease in stress. And this is very important to highlight because we know that not only the numbers go down, but we are actually finding how there are changes in the brain that mediate those changes. We have also been very emphatic in serving a diverse population. So in our MIT trials, we have sought to recruit a diverse and marginalized population as well. So as you can see here in the pie chart, about a third of our participants are from Latino community, Spanish-speaking, about a third are from another minoritized communities, including Blacks and Asians descent, and about a third are non-Hispanic whites. Here I want to share with you, for example, some of the work I have done with Latino caregivers who speak Spanish because something that is very close to my heart is that when I am in clinic sometimes and I see people who do not speak English and speak Spanish and have limited English proficiency, I didn't have a lot of resources to offer to them. Even the support groups, sometimes we don't have support groups or social workers that speak Spanish, and I didn't have much to give them. So I took on the task of adapting this intervention to make it available for them. And similarly, as you can see in the graph here on the left, there are reductions in symptoms of depression, even up to 3 weeks during participation in the study that were persistent up to 4 months afterwards. Similarly, participants reported decrease in their feelings of caregiver burden and increase in mental well-being. But not only that, but we are taking this further because we really want to make this available for everybody everywhere. And I know people are seeing this talk from different states, even different countries. And that's what I want to say. We created a mobile app because the goal is to have this intervention available through the phone by downloading an app at the fingertips that you can use in different parts of the country and the world and in different languages. So here I have the example of our current intervention in English. It not only has the mentalizing imagery therapy, it also has a module on caregiving skills. How do we manage different behaviors, agitation, sleep issues, things that happen in people living with dementia, and brain health. And in addition to that, on the right panel, we have a chat, which is a very cool part of the application because they can interact with other caregivers that are also using this application and support each other and help problem solve, navigate different things that they are going through. As I mentioned, I also am very committed in developing this intervention not only for English-speaking audience, but different languages, and so far we have translated and have it available in Spanish. And similarly, we have the content that has been adapted for these caregivers. And I want to share with you a very short excerpt of a larger video that we have, so you can meet some of the caregivers that have been through this intervention, and you'll also have the chance to meet my colleague, Dr. Felipe Jain, who is part of the Department of Psychiatry here at MGH.
Meditation has helped me slow down, and even if it's just for that 18 minutes a day, live in this pure perspective of a place of love. And caregiving is born out of love.
Did you like having all of the material on a mobile application?
Oh, God, yeah. Yes.
What about that?
Yes, of course. It's at my fingertips. Who wouldn't? It's a gift.
You can teach old dogs new tricks. And so, yeah, I mean, I think it would have improved my life. No doubt about it.
I can't even believe that something like this could make such a big change with me.
Even when, after my loved one is gone, I'm still going to use the app because it has a lot of exercises in there. And it's nice. It's a nice app. Helps me go to sleep.
I will highly recommend everybody with an opportunity like this to just grab it and take advantage.
With Alzheimer's and other related dementia, we watch our loved ones lose connections in their ability to be able to do things, connections to other people. So for me, as a caregiver, to be able to find additional methods of how to connect is really profound and impactful to me. And I think it is for any caregiver.
Give yourself this gift. It can be life-changing.
I hope you've enjoyed hearing about our new program from family caregivers who have experienced it. If you'd like to learn more about how you or a loved one could get involved, or about how you could support this program, please reach out to us.
And what are the next steps? Where are we taking this next? We know that Our research is the first to demonstrate that it is possible to help even those caregivers who are more seriously distressed, even those feeling overwhelmed and having those dark thoughts. Next, we plan to create the integrated multicultural program to advance caregiving therapy at MGH called IMPACT. And we are working on creating this to make it available for everybody. And our goals are to support all the family caregivers of neurology patients at MGH who need help and spread best practices of effective care globally. And here I want to mention that there is a role in everybody, of course, taking advantage of these opportunities and also participating in many different ways. And something that I want to mention today is that the role of philanthropy is immensely valuable, because with that, it's a key and critical role that we have in allowing us to expand and launch programs like what I and my colleagues are about to create. And the healthcare system, unfortunately, at this point in time, doesn't cover a lot of those things. You see, you go to the doctor and they prescribe you a medicine, do their best to give you some advice, but then what else? What else do we have to offer? And a lot of these things we need to show how valuable they are, the difference they make, so we can obtain funding and change the laws to make sure that these type of interventions are covered. So we are so grateful for partners like the McCourt Foundation and all the people that are interested in supporting this work. And with that, I want to thank my collaborators, supporters, and all of you for being here virtually and in person. Thank you.
If you have questions in the room, just raise your hand and we'll get you going. And then maybe if there's some online as well that we can kind of use as well. Why don't we start with someone in here? Yeah, please.
Hi, my name is Shirley, and first I have to say thank you to the McCourt Foundation, everybody that's on that list, my support people, whatever your business is, I do my business to them. But thank you so much, Doctor. It's such a pleasure to see you again, and I'm sorry I didn't catch your name.
Mike Erkinen. Yeah.
Mike, nice to meet you.
Yep.
Oh, God, you don't want to give me a microphone. I might not put it down. Anyhow, I traveled all the way from Dartmouth, Mass. To get here, born and bred Bostonian, and it's worth an hour and a half, and this is free. I got all this great stuff. This is like fabulous. And I have experience with a dear friend of mine who I grew up with, who was diagnosed with early Alzheimer's at like age 40. And it was awful to see what happened to her. And this type of stuff wasn't available. She went to a primary like 10 years ago. They didn't have what we're doing, right? So it's just encouraging. And I wish there was more, like when you go to your physician, they'll do the best, they do the clock thing and they diagnose you, but there's really not a lot they can do. Like, it's about time we start studying the brain. We study skin, we study all this stuff, but it used to be, well, when you die, we'll study the brain, but not anymore because of programs like this. So it's like it's getting better, just like if I had a heart attack. I go see my primary, he's gonna check me and he's gonna be like, gee, Shirley, you probably should go see a specialist. Off you go to a cardiologist, right? And this is no like ding on anything, but let's come down, it comes to do, re, mi, money, which is good. But what I've found is her solution was she ran out of money. No, they had to take her to assisted living because she was beating up her family. That's kind of what happens. Then she ran out of money with assisted living. Then she had to go to a nursing home. And I don't care what anybody says. I'm an RN. Nursing homes are awful, and DPH comes in, but whatever. So to see her went from somebody who was so active, big job with the state, traveled, went to more countries and educated, and to see her, it was horrific. Then I took care of my mother, dementia, right? Hardworking Irish, immigrant, that's what you do in Boston, and to see her downfall. And I took care of her for 5 years. Nobody told me that this stuff was available. Absolutely has the suicidal thoughts. You tell somebody that, first of all, they're gonna call you 911 and ship you off to the hospital. The stress, it's like incredible. But the good news is, like, it gives me a lot of hope to come here. And I'm telling you, if anybody has this, whatever, there's much more resources. And I'll say this closing, support groups are good, but you're living in the problem, not the solution. So if you go there and you're like, I'm gonna have a mental breakdown, my mother's doing X, Y, and Z, but at least now, that app, you could really use that for anything. And it's just so encouraging that, like, you people could do anything in the world. Like, you came from Columbia, you know, and to come and help us, it's just wonderful. I just, you know, God bless the McCourt Foundation. They do a lot of hard work. So I better shut up because I love to talk. So thank you so much for being here. Much appreciated. I don't even know if I asked a question.
Thank you. I'll just respond and say, I think and thanks for sharing your story and your experiences. And I think that's right, that there are, caring for a loved one or knowing, and we all have stories like that where we know someone who's gone through some of the most challenging moments of their lives and their caregivers' lives. And I think we've talked about different ways to get our arms around this major problem. We've talked about interventions for caregivers, and we've talked about even early stage trying to intervene on the disease itself. And I think you're onto something where the idea is that we need to be holistic in our approach and take many, many angles at this, because they're all going to make a difference, in time. I don't know if you have more to add. Yeah.
Anyone else in the audience that has other questions? We have some questions from the virtual audience that I want to tell you. So the first one, you can start with this. With an early onset Alzheimer's disease diagnosis at age 60, are there steps to be taken now to slow progression of the disease? And are there promising clinical trials in Boston, or this person mentioned in the Scottsdale area? But
yes, thank you. So yes, the diagnosis at the age of 60 is early. Early onset Alzheimer's is defined by the onset of symptoms before the age of 65. So it's uncommon, but it does happen. And we see that often in our clinics. And there are now disease-modifying agents that are targeting Alzheimer's at any age, and that's kind of what the focus of my talk was really on looking at what's available now, lecanemab, soon to be donanemab, we hope. At least at our site, it's available out there now, but at our site, we hope to add donanemab, and there are a number of trials that are looking at amyloid-related mechanisms, also tau-related mechanisms, and a host of other mechanisms that we hope this is the first, wave of what we hope to be, a number of disease-modifying therapies in the future. If you're interested in being in a trial here, the Center for Alzheimer's Research and Treatment at the Brigham in Women's is a great site, and we have a number of active trials that are enrolling now. Thanks.
Yeah, I want to also compliment that there is hope, and that navigating this condition, it's hard, and there is also hope. And we want to create that hope, not only for each one of you here, but also for the future. What's for the next generation? So it's so important to participate in research, and everybody, not only people that are more used to participating in research, but perhaps other marginalized communities, as I mentioned, that we historically had been less interested for many reasons to be part of research, but now knowing that there needs to be a change, and it needs to be inclusive and representative, and that we're doing a lot of research both at Brigham, at MGH, and hope that some of the you that are in person today may stop by the table outside the MADRC that has all the resources, and of course online with the websites that Dr. Erkinen shared. There is another question. Someone asked, can dementia from Parkinson's disease be distinguished from dementia by Alzheimer's disease? If so, how? Are there different treatments? And the answer is yes. That's what we do. Experts like us who work in a memory clinic, in a neurobehavior clinic, where people present with different symptoms. They may come because they have difficulties with memory, or they may have difficulties with some function of visual abilities, navigating their space, or language difficulties. And our job is to explore those to find out what's the cause. And that's the reason we not only take a very detailed history, personal and family and exposure, etc. But also we do brain scans such as MRI, PET scan, and sometimes even lumbar puncture studies to get to the root of what's the cause. And nowadays we are really able to distinguish many of these different causes that include Alzheimer's being one of the most common dementias. We also have Parkinson's disease that affect cognition as well, but also vascular conditions or Lewy body dementia and others. So the answer is yes, and the recommendation is when someone is experiencing changes in their memory, their thinking, or their cognition, it is important to ask your doctor, your primary care doctor, to see a referral to a specialist to explore those, because now we may have treatments available, as we heard today, in the early stages, and also you can be part of research studies.
Great. Yeah, in the room.
Yes. In your study, you were talking about the drug that the one you were proposing. If it's FDA approved, I think that's what you said. The people that you're choosing, these people are at a stage of dementia, not Alzheimer's.
Great question. Oh, sorry.
And part two to that is the reason you do the placebo is because you're comparing and seeing if these people who not taking the drugs will not have Alzheimer's at some point in time. And I have a question for the young lady. I'm sorry, I don't remember your name, and I apologize. In your impact, you talked about it's part of respite care tied into that impact, that website you were talking about, that program at MGA. That's my question.
So I'll take the first one. So it's a great question. Really, what's the difference between dementia and Alzheimer's? And are those two things the exact same thing? Are they referring to the same, or are they different? And I think one of the ways to think about, the term MCI and dementia, that's a way of understanding an illness on how severe one's symptoms are. And actually, you can have dementia and not have Alzheimer's. As we were just hearing, you can have dementia from Parkinson's, you can have dementia from vascular disease. So you can have dementia from a host of other causes. Alzheimer's disease refers to the specific biological disease in the brain. And it's defined by the way it looks under a microscope. Again, we don't usually see that when someone's alive, thankfully. But what it is there's amyloid and tau in the brain. So we do our best to understand who has amyloid and tau in the brain by getting things like spinal taps and amyloid scans to make sure that we see of everyone who has dementia, what percentage of them have Alzheimer's, and that's where we use things like amyloid scans and spinal taps. Increasingly, actually, a blood test, which is an exciting kind of area of the future. And your point about we always use a placebo because there's this thing called the placebo effect, right? If one group was on a drug and the other didn't get any intervention at all, just the fact that you're receiving a drug, you're showing up at a clinic and you're being treated in a medical facility, that itself has a benefit on one's outcome. It's a well-known effect. It's called the placebo effect. So we want to make sure that we are giving everyone this. It looks the exact same. They're in the same room. They're getting the same amount of infusion, but just one's a drug and one's a placebo. And therefore, we look at what's different between a drug and a placebo to make sure we get rid of all those other features that can happen in just a placebo alone. Yep.
Yeah, I want to add as well that actually Dr. Erkinen is not proposing that study. It's been already done. So it's something that has been completed and published in the literature, something that's already there. And it's something that I want to mention is that who participated in that trial. As you saw, there are about 1,800 participants because, almost 800 were in the placebo, the other half were in the active treatment. And you may wonder who participated there. Who are they? Are they like me, like you, like other people in this room? And something for us to be aware is that most of the participants in that trial and the donanemab trial are non-Hispanic whites. And the question is, would it be the same? Because I see people of color here, and I love that, and also people from diverse ethnic backgrounds. And what I want to bring, the point I want to make is that it's important because we are part of this. We have these diseases in our communities, and we also need to be part of the trials and the studies. So this is like a plug and a motivation that we all participate and sign up for these trials, because we need to be diverse, represented there, because what we are seeing right now are the results. And now we are telling you, all of you here, oh, look, this may work, and this may be good for certain people that have these characteristics. And how do we go deeper and look into that and also become part of this emerging landscape of new treatments? So I want to motivate you. And thank you for your question about the IMPACT program. That's something we are working on. So far we have gotten to the point of having the mobile application, and that's the reason we're working hard to secure funds that we can really launch this program and have it available to more people. And part of what you mentioned, the respite care, is an area that is very important. And the program itself wouldn't be able to provide respite care for all the caregivers that need it out there. But something that is very important is actually, one, being aware that those resources exist. Second, how do you navigate even to try to get those resources? And that's very important. And that definitely is something that we are incorporating in our intervention as part of the therapies that we're giving and resources for the caregivers. There is another question from the virtual audience. With the growing evidence that amyloid is not causal, but is more a result, and that viruses may be the real cause, are research funds and drug development starting to move in that direction?
Great question. So is amyloid king is a question that's out there, right? And I think my take on this is that amyloid is an important player. The clinical evidence now shows that taking amyloid out lowers your rate of memory loss. It's hard to argue with the fact that targeting amyloid, especially in the early stages of one's illness, can have a positive impact. So amyloid is an important player in Alzheimer's disease. I'm personally not one who thinks it's the whole story. I think amyloid, what causes amyloid to accumulate in the first place, and then what happens when amyloid's there for a while, and all the downstream effects, and all the impacts on the immune system in the brain, et cetera. It's a complex tale that's intricately woven together. So I think starting with amyloid, perhaps the lowest hanging fruit, makes sense. But I think as we advance, these other mechanisms are going to be much more important. And they'll be supplementing and adding to the effects of taking out amyloid, or perhaps even our understanding of amyloid and how to target it may change, right? Amyloid, you might not be a monolith, right? It might be there are certain types of amyloid, or when amyloid arrives at certain moments in one illness, perhaps have more of a disease a deriving effect. So I think there's a lot more to come in the future, but it made sense to target amyloid first, just given that it's always there in Alzheimer's disease, almost because that's the way it's defined. So,
Thank you, Mike. Another question is, how effective are the current recommended medications for dementia and Alzheimer's disease in decreasing symptoms and maintaining memory? And that's a very important topic, because we all want to have good care, not only to make a diagnosis so we can plan for the future, prepare what's next, what do we need to think about, but also receive therapies for the symptoms that people with memory loss and other symptoms related to dementia experience. And we know that the medications that we have prior to lecanemab and donanemab and this type of monoclonal antibodies were not disease modifying, meaning that they are like symptomatic treatment. And although they did not really improve memory or function, they slow that progression and decline over time. And even to this moment, we don't have a cure yet, and even the new treatments do similarly on that with modest effects and also some side effects. So it is important to receive care and that everybody has access to care to manage the symptoms because we can treat some symptoms that become more problematic because we know that there may be not only the memory loss, but someone can experience changes in behavior and they are acting different, or sometimes they may be more agitated or aggressive, or they are not sleeping well, or they may have delusions of thinking that someone is stealing their things or others. So we do have medications that can help with that, and it's important to have the guidance of a specialist who knows how to treat this, to counsel not only about what medicines, but also what behavioral interventions we can implement to manage all of those symptoms that can come with the condition.
For those, on the average, during the 18 months, how much is the cost? Is it covered by Medicare? Mm-hmm. And is there any other new treatments besides what you talked about on the scene for treating Alzheimer's?
Yes, so cost is a big issue. The cost of the drug itself, out of pocket, is $26,500. And that doesn't include the facility fees and the MRI charges and so on and so forth. And it's hard to get your arms around the exact estimated cost of everything out of pocket, but needless to say, it's very, very high. Medicare, as they do for every your medicine, they cover 80%, and the other 20% is on the patient. Now, many patients have supplemental healthcare insurance, and that, in our experience, covers the rest. So if you have Medicare and you have supplemental insurance, it's likely you'll get covered 100%. I think, but that's worth making a phone call before you elect to be on the drug or not to make sure you're covered. There's also private insurers, and there's been a range. We've worked very hard to, partner is one way to put it, but to make sure that our patients who have private insurance are covered. And for the most part, we haven't had a ton of issues getting folks covered, although there's been a back and forth with the insurance agents, the insurance companies about making sure that does happen. So private insurance, at least in our experience so far, has covered it, and then Medicare covers 80%, but the other 20% is often covered by supplemental if someone has it. And then other drugs. Yeah, I think we mentioned a few. There are other drugs that are related to amyloid that are in the sort of a research pipeline, and there are other drugs related to a tau that are in the research pipeline, and then there's other mechanisms, and they're very exciting. I think I will say a lot of drugs are exciting early on, and then we want to wait to see the ultimate outcome, which is what we want to see here, which is a change in memory over time, and that we're waiting on. So yeah, this isn't just these two drugs and then that's it for a long time. I think there is optimism and hope that this is the start of hopefully will be a number of options in the coming years. But we'll see what it shows. Yeah.
We have a question also from the virtual audience. I am the caregiver for my husband, diagnosed with dementia, Parkinson's disease, and Alzheimer's. In addition to his neurological challenges, he has other physical complications requiring various doctors who order tests, prescribe various medications. With all these, why don't the various hospital systems, example, partners like he, freely network to provide data in a central database for all in the medical community to access and review? How can I, as a caregiver, navigate this process without authorization to change anything? Well, thank you so much for that question. And actually, that's an example of how complex the healthcare system is, from accessing to navigating and feeling lost. Like, what do I do here? And to say that it's very important, we work as a team. And it's important for all of you and the ones that are watching know that we are a team. And you not only work with your doctor who gave you the diagnosis and the treatment you currently have, but also, as we said, the caregiver and the other medical conditions you may have. It's important to coordinate with those doctors as well, and not feeling that you just have to follow your care with one person. We all communicate, by the most part, with each other, but it is true. I think more than an answer, I have to say that I feel you. I am aware, we are aware of this breakage, that the healthcare system is not complete. It's very hard to navigate. And actually, that's the reason we are doing this work in creating interventions on helping people navigate this journey that is complicated and for which at the current moment, some insurance have navigating service like caregiving navigators and help with that, but not everybody has access to that. Sometimes people even pay for care managers that they have to pay out of pocket. But the idea is that this is covered for everybody, not only for people that have more means, and hopefully we'll get there sooner than later.
How long is an infusion? And are there any side effects?
Yeah.
And
great.
one other question is, why, how did Mass General become associated or affiliated with this particular Alzheimer's drug?
Great. So the infusions are always 1 hour, at least of lecanemab. Donanemab, again, not here yet, but it's approved and we're trying to get on, is a half hour in length. But lecanemab is 1 hour. The day, though, the time you spend in the infusion center varies a little bit over time. So up front, you spend a better part of you spend about half a day in the infusion center because we watch you for a few hours after the infusion. I didn't mention this, but there is not uncommonly, you can have an infusion reaction, a headache, nausea, fevers, chills, diarrhea, rash, any host of symptoms and immunological reaction to getting the infusion. It's usually mild. Most people don't have this. It's usually mild and it's usually self-limited, but we watch it to make sure there's not a more serious reaction. And that on the first infusion is a 3-hour observation window. The next 2 infusions are a 2-hour observation window. And then after that, all subsequent infusions are about a half hour. So over time, you're there at the infusion center for a much shorter amount of time than you are on the first few infusions. How did we get associated with lecanemab? Well, one, we read the literature like any other institution would, and we actually were, I will say it's more than that, we were involved in the trials that led to this drug being approved in the first place. So we were kind of involved in this very, very early on. And when it was approved, we had a set of doctors who were already thinking and talking about this and ready to go to get this, a drug on the formulary so we could offer it to our patients. And I will say the Alzheimer therapeutic program is really run by and motivated by our doctors. It's really kind of a clinician, a driven program. And it's been the efforts of our doctors tirelessly, well before it was approved and then subsequently to make sure that we are offering this safely and expanding our access so we can, have folks who are interested in being on it have the option for that. So really, it's really a physician, a driven program.
Yeah, and I want to add that it's not that we are like associated with a specific pharmaceutical company or something like that. It's more that we are at the forefront of the developments of the cutting edge science research. And of course, we want to be some of the first ones that bring any therapy, like anything that can help our patients, we'll do it. And will help implementing those programs. And we have been very fortunate. I have been working with Dr. Erkinen and many other doctors at MGB who we are coordinating in, creating, coordinating, monitoring, doing everything that is needed to keep this program going and expanding, because there may be probably soon new treatments and actually new diagnostic tools that will come our way. We haven't talked about other markers, but I know many of you have read about blood biomarkers, and people ask, what about my children, and things like that. So it's to keep your mind open about the many opportunities that are available there to get involved in research and what the future will bring. And we have time for one last question, if anyone in the audience, before we finish.
Thanks. Well, you talked about drugs all along, but a few years ago I heard about devices that emit sound and light, and there were studies ongoing about those, and I was wondering if you could update us about those studies.
Yeah, great question. So I'll give a little bit of a background. With aging, so the brain, if you put an EEG, right, those little stickies and listen and you can see the kind of waves of one's brain, there's different ranges of frequency, a few beats a second, up to 40 beats. And the highest frequency in terms of beats per second is called, a gamma. That's what it's called, but that's sort of how the frequency is defined, up to 40 or so. And it was shown that, tell me if I'm wrong about this, but I'm not like super good at this, but that with aging, and particularly with illness like Alzheimer's disease, the amount of a gamma frequency that you have in the brain gets lower over time. And the idea was, well, rather than you using a drug to target amyloid and all these other things, why don't we just restore gamma frequency? And how do you do that? You flash a light at 40 hertz, 40 times a second, or you play a sound, 40 times a second, and you can actually induce the brain to make gamma waves. And there was some early excitement about does that actually shift amyloid, out of the brain or into the cells? And it's my understanding. I don't know for sure, but I think those are still in the trials, and they haven't been read out yet, as far as I know. I don't know if you have any other updates on that.
Yeah, and in fact, actually at MGB, there are people that do research on those type of therapeutics. So we don't have them clinically available. In other words, if you come to clinic and you see one of us and you said, I want to have one of those devices, they are not available for us to prescribe and say, go use this instead of taking this pill. I also want to, I know we are short, but before we finish, we didn't get to talk about diet, non-pharmacological interventions, and other strategies to prevent dementia and even to treat, and prevent that decline to being, faster and make it slower. But it's very important to be aware that there are things you can do to take good care of your brain, which include a healthy diet. Even in the previous session, in the MS session, they talk about the Mediterranean diet, having the best evidence for brain health. And similarly happens in the world of Alzheimer's disease and other neurodegenerative conditions. Something that is very important and has a lot of research supporting that is exercise and physical activity. So it's very important to put on your tennis shoes and do what you can to move and stay active. Similarly, I love that many of you are here with your spouse, friends, because staying socially engaged, learning new things is also good for your brain. Community, connection with nature. And overall, before we finish, I want to say there is hope. We are hopeful for the new treatments, for the new therapies, and again, for the prevention that is ahead. And if you or your loved one are living with dementia or Alzheimer's disease, know that we are here. And at Mass General Brigham, we do our best to support our patients and love foundations like the McCourt Foundation that strive to provide the best for the people living with these neurological conditions. So thank you all.